Mucormycosis is a serious but rare fungal infection caused by a group of molds called mucormycetes. These fungi live throughout the environment, particularly in soil, decaying organic matter such as leaves, compost piles, or rotten wood. People get mucormycosis by coming in contact with the fungal spores in the environment. For example, the lung or sinus get infected when someone breathes in the spores. Most people come in contact with these fungi every day. These fungi are not harmful to most people. However, certain groups of people are more likely to get mucormycosis, including people with diabetes, people with cancer, organ transplant, long-term corticosteroid use, injection drug users, and neutropenia, too much iron in the body, prematurity and low birth weight, or skin injury due to surgery, burns, or wounds. There are 5 major clinical forms of mucormycosis. Of these, rhino-cerebral and pulmonary infections are the most common. Symptoms may include unilateral facial swelling, headaches, nasal or sinus congestion or pain, serosanguinous nasal discharge, and fever. As the infection spreads, ptosis, proptosis, loss of extraocular muscle function, and vision disturbances may occur. Necrotic black lesions on the hard palate or nasal turbinate and drainage of black pus from eyes are useful diagnostic signs. Pulmonary mucormycosis generally occurs in patients with hematologic malignancy or profound neutropenia. The symptoms are non-specific and include fever, cough, chest pain, and dyspnea. Angioinvasion results in tissue necrosis, which may ultimately lead to cavitation and hemoptysis. Cutaneous mucormycosis may be primary or secondary. Primary infection is usually caused by direct inoculation of the fungus into disrupted skin and is most often seen in patients with burns or other forms of local skin trauma and can occur in patients who are not immunosuppressed. Primary infection produces an acute inflammatory response with pus, abscess formation, tissue swelling, and necrosis. The lesions may appear red and indurated and often progress to black scars. Secondary cutaneous infection is generally seen when the pathogen spreads hematogenously. Lesions typically begin as an erythematous, indurated, and painful cellulitis and then progress to an ulcer covered with a black scar. Gastrointestinal mucormycosis is less common than the other clinical forms and is believed to result from ingestion of the organism. It typically occurs in malnourished patients or premature infants. The stomach, colon, and ileum are most commonly affected. Non-specific abdominal pain and distension, nausea, and vomiting are the most common symptoms, and gastrointestinal bleeding can occur. It is the most common form of mucormycosis among neonates and is challenging to diagnose partly because of its clinical resemblance to necrotizing enterocolitis, a far more common disease. Disseminated mucormycosis may follow any of the forms of mucormycosis. A definitive diagnosis of mucormycosis typically requires histopathological evidence or positive culture. Early recognition, diagnosis, and prompt administration of appropriate antifungal treatment are important for improving outcomes. Amphotericin B, posaconazole, and isavuconazole are active against most mucormycosis. Surgical debridement or resection of infected tissue is often necessary, particularly for rhino-cerebral, cutaneous, and gastrointestinal infections. There is no vaccine to prevent mucormycosis. For people who have weakened immune systems, there may be some ways to lower the chances of developing mucormycosis. Try to avoid areas with a lot of dust, like construction or excavation sites. If you can't avoid these areas, wear an N95 respirator while you're there. Second, avoid direct contact with water damaged buildings and flood water after hurricanes and natural disasters. Third, avoid activities that involve close contact with soil or dust.